Good evening, everyone, and welcome to Go Rural Virtually. Before we begin, I'd just like to make acknowledgement of country. Today we stand in footsteps millennia old. May we acknowledge the traditional owners whose cultures and customs have nurtured and continue to nurture this land since men and women awoke from the great dream. We honour the presence of these ancestors who reside in the imagination of this land and whose irrepressible spirituality flows through all creation. I also acknowledge that I'm presenting tonight from the lands of the Turrbal and Yagara peoples, and acknowledge the traditional custodians of the various lands in which you all study, work and live today, and any First Nations peoples participating in this presentation. I pay my respects to elders, past, present, and emerging, and celebrate the diversity of First Nations peoples and their ongoing cultures and connections to the lands and waters of Australia. So welcome again. My name is Meredith. I'm the Future Workforce Team Leader, and on behalf of Health Workforce Queensland, I would like to welcome you to Go Rural Virtually. The topic for this evening is titled The Sound of Silence, Giving Voice to Workplace Sexual Misconduct. Because of the work the Future Workforce team does to support the health career journey of students, we have awareness of intercollegiate sexual misconduct occurring at many levels in health workplaces. The lack of visibility, alongside the silence surrounding occurrences, and uncertainty regarding reporting options prompted us to seek out tonight's speakers to guide students, early career graduates, and junior doctors through this complex landscape. I'd now like to invite tonight's speakers to introduce themselves. Louise, could we start with you, please?
Yeah, sure. Hi, everybody. It's always interesting talking on Zoom because you can never see a lot of faces. So welcome from slightly sunny Canberra. I'm on the Ngunnawal and the lands of the Ngunnawal and the Ngambri people. And I'm a GP in Canberra. I've worked rural and remote. I've worked in Broken Hill. I've worked in small rural towns. And now I work in Canberra, which can be a small rural town in itself. My background is that I am the lead editor of a textbook, which is global, looking at sexual harassment of doctors by doctors. It's been about a decade's worth of work and hopefully will be finished in a few weeks. And I just wanted to say at the start that I am not an Aboriginal woman, but I am an auntie in this profession. And there are many of us who stand against things. When you're young, I was quite meek, believe it or not, as a student. I said very little and I was very quiet. But remember that you have the women and men who've gone before, and we see you, and you should never feel that you have to do this alone. There are always those of us who are standing up for you and standing with you. So I just wanted you to be aware of that as we go into today's session.
Thank you, Louise. And we'll now ask Victoria to introduce herself.
Thank you. Thank you very much. That was beautifully said, Louise, and I echo those comments. I'm not a healthcare professional at all. I'm someone who has a strong business background, and more recently I've been drawn into academia. And I'm currently doing a PhD looking at junior doctors and what they do and don't speak up about at work and why, from the perspective of an area of research called employee silence. So you can see why I've been invited into this evening's discussion. I've become very passionate about this topic and very concerned about the silence that I see in the healthcare workplace, particularly hospital-based workplaces. And yeah, very interested to see where I can contribute to the discussion and any insights you might want to know about this topic. So thank you.
Thank you, Victoria, and welcome. And Stephanie.
Hello, everyone. I'm Stephanie Pomerell. I'm a GP that is post-training but pre-fellowship. At the moment, I'm in Lennox Head, but I usually live on Bribie Island where I work, and I also work in Woodford Doctors. Meredith and I met in my medical school, trained at UQ, and the topic is a personal one for me in the sense that I have experienced sexual misconduct in the course of my training. I was a final year medical student. There is much to be said about this, and what I will probably preface what is about to come in the discussion between all of us is that we could talk for 5 hours and not draw breath easily. So there's a lot to talk about, and there's also very much the acknowledgement that this conversation could bring up things for people, and that we are more than happy to chat about that as needed as we go through messages on the chat. I think Meredith will probably have some more housekeeping in that regard in any case. So I'll hand you back over to her.
Thanks, Stephanie. So as you heard, our speaker's experience, work and research is primarily located within the medical workforce. But tonight's discussion will focus on intercollegiate sexual misconduct and therefore is relevant to all disciplines and health settings. And as we understand that tonight's topic may contain content that is personally upsetting or confronting, our speakers will stay on at the end of the session for one-on-one confidential conversations. And we also encourage you to ask the speakers questions by using the chat function. So to start tonight's conversation, Louise, can I ask you to provide an overview to the students of what we mean by sexual misconduct? You're on mute, Louise.
That must be the most famous phrase of the last few years. Sure. So sexual harassment tends to be an overarching term. I tend to use the word harassment because misconduct sounds smaller. And it ranges from everything from touch, from texts, from inappropriate images, all the way up to rape. And it depends on where you are in the world, how these things are defined, and it depends on state by state how these things are defined. But the thing that I would say right up front is that healthcare is an uncomfortable thing. I don't know about you guys, but, when you first start, you're a bit embarrassed about asking someone to open up their top so you can examine them, or you might be embarrassed when someone throws up and you feel sick, or you might faint at the sight of blood. There's lots of things that make you uncomfortable. And sometimes, when people tell off-color jokes, or they seem to bring sex into every single tutorial that they give, like I have certainly seen before, or you're standing very close to somebody in surgery and you're wondering if maybe this is right, maybe this is wrong. Sometimes you need someone to chat about that discomfort with, because some discomforts in healthcare are expected and some are not and should never be, but it can be sometimes difficult to tease that out. But in terms of what the law would say was sexual harassment, the intent does not matter. The hard thing in healthcare is there is a difference, and this is what makes it tricky for us. If there's an old man coming out of an anaesthetic and, he says terrible things, often that's not his fault. It's not intended. It's just an automatic response. And sometimes it can be hard to know whether or not somebody is doing something deliberately or not. Now, out in the world, it wouldn't matter. In healthcare, sometimes it does. So it's tricky. And I don't think you should ever feel embarrassed about the fact that you might not be able to pick which is which. That's what people like us are here for. Find someone safe, talk about it, and see whether that discomfort is just sort of getting used to healthcare and the things that happen, or is just plain wrong.
So I think given there's so many overlapping definitions to describe what we want to talk about tonight, we'll stick with sexual harassment as the overarching term. And also to ask, sexual harassment isn't confined to females. How does it look otherwise?
Yeah, so it's all genders. And we know that women, people who identify as women are at greater risk. We know that people with greater intersectional disprivilege are at greater risk, but that gets confused because often, for instance, my international medical graduate colleagues are concerned about their visas, so they report less. So sometimes, although we know that they are more likely to be targeted, we also know that they're less likely to report. So it gets very confusing. But around the world, I will say that the prevalence is greater than 0, and that women are more likely to be the survivors. And I use the words survivors and perpetrators. There are targets, there are all sorts of aggressors, there are many ways, but they're my words because I had to pick some and I just did. So it is more likely that women are survivors. It is more likely that men are perpetrators. We hear very, very little from male survivors, and that's extremely sad. But one thing I will say that they aren't. A survivor is not a snowflake. They are not oversensitive. They are not needing resilience training. I cannot tell you how many times I have to make that argument every time I present. And the perpetrators are not bad apples. They're not just, oh, he's just a little bit odd and he's getting old. And this is not true. It is a cultural problem. And the one thing I would think about, you guys would perhaps think about, is that if you are a predator, if you do have a tendency to want to actually sexually harass people, which discipline would you pick? You'd pick healthcare. And so regardless, we will always have people in healthcare. And I will say that our national training survey tells us that it is more likely that you will be harassed by someone higher in the hierarchy. It's more likely that you will be harassed from someone from your discipline, but not necessarily. So in medicine, 50%, so some people get harassed by different people, so it doesn't add up to 100, just letting you know, but 50% are harassed by a colleague, another medical person, but 33% by nurses and 33% by patients. So it is not a single discipline, it's right across the field, and it's something that we have to learn to manage better.
Thank you. Victoria, is there anything that you want to add at this point?
Not specifically, but we did discuss the potential to talk about what silence is and how a culture of silence comes about. So I'll just briefly speak to that. Now, just to let everyone know, the context that I think about silence is in relation to workplace silence. So employee silence is a specific thing, and it refers to, as it says, silence in the workplace context about workplace related issues. So we're talking quite in a focused way here. So how a culture of silence occurs in a workplace, it starts with the individual. So individuals are silent or make a choice to be silent or feel that they have to be silent. But if that behavior becomes habitual, and if enough people start experiencing the same sorts of feelings about, oh, I can't speak up about this, I can't speak up about that, that's when it starts to form a climate, what's called a climate of silence. So at that level, it's moved from the individual level to the group level. So that's when it starts to become a cultural thing, and it characterizes the workplace, and it becomes a norm. It becomes a norm that people feel they can't go up against. So that's it in a nutshell.
I think that's a great introduction, and we'll delve into that in more detail a bit later on. But now I'm going to ask Stephanie to take us through the case study, a hypothetical case study that she composed, and so we can explore sexual harassment in more detail together. And we also acknowledge that the case study, it's not exclusive to women or particular ethnic groups. We've just taken a broad brush approach. Stephanie, do you want to read through the case study?
Sure. So we've got Sarah here, who's a physiotherapy student, and she was undertaking an orthopaedics rotation in the outpatient department of a Brisbane-based hospital alongside the surgical team. Her experience took a distressing turn when she overheard a group of male registrars engaging in what she thought was an inappropriate conversation. The registrars were discussing a recent visit that one of them had made to a strip joint, which included making derogatory comments about women. For Sarah, she had a feeling of unease, who felt challenged by their unprofessional behaviour. Although she wasn't directly included or involved in the conversation, she couldn't shake off that feeling of discomfort. As a student, she felt powerless to intervene or speak up against that inappropriate conduct. This feeling of powerlessness only intensified when, some 30 minutes later, one of the registrars grabbed her backside as he passed her in the corridor. She felt very taken aback. She was quite shocked and evidently violated. But this intensified when he found it quite amusing. Although she was uncertain how to address it directly, she quickly decided to hurry along with her clinical duties, trying to maintain a professional front in front of her patients. However, the incident lingered in her mind, so she spoke with a colleague about it who dismissed her as being overly sensitive. So then she felt uncertain as to whether to report the misconduct, confront the registrar, or simply just push through the placement. Both incidents highlighted the pervasive issue of workplace harassment and the challenges faced by students like Sarah in navigating such situations. Despite her dedication to her profession, Sarah found herself in a vulnerable position, unsure of how to assert her rights and be treated respectfully in the workplace. As she contemplated her next steps, Sarah reflected on the importance of speaking up against inappropriate behaviour and advocating for a culture of respect and professionalism in healthcare settings.
Right. Thanks, Stephanie. So, Victoria, I just want to pause at this point to ask if you could give us a brief overview of the physiological and, I guess, emotional responses a person might have in response to sexual harassment.
Yeah, I think I might hand that one over to Stephanie. I think that one was
All right, Stephanie, this is your question.
So the experience of sexual inappropriateness is probably something that most of us have actually come across before attending this webinar. It's extraordinarily common, and even with the statistics on rape, 1 in 5 women have experienced rape or sexual assault. But in reality, I feel that that figure is much higher due to underreporting. People don't like to talk about this. So when you have a society that normalizes how things are conducted between the two different sexes, and I will be using a duality here, I'll come back to that point in a moment. But what generally tends to happen is that the ones that are more perceived to be powerful will repress the ones that are perceived to be more vulnerable. And there are, generally speaking, and most people will have learnt about this no matter your background in terms of healthcare training, the fight or flight response. So the sympathetic nervous system kicks in, adrenaline starts pumping, and your muscles get ready to run away from or fight the perceived threat. What's often not spoken about, and it's a theory that I use extensively in my work with people who have experienced trauma, it's called the polyvagal theory. I'm not sure, Wendy, if you have the document that we can distribute to the participants, but there's other categories that are involved in the fight or flight continuum, and that includes fawning, where one goes to appease the perceived threat so as to reduce the impact of that threat. And the other one is freeze, where you are, in a sense, disassociated from your body and paralyzed and unable to move. So it's another defense mechanism that allows whatever is going on to go on. Fantastic. Fantastic. So I hope everyone can see this is something that we can distribute to everyone. But I will actually draw your attention to hypofreeze right at the right-hand side. I think I always do things opposite because I'm dealing with patients, but hypofreeze in the sort of purpley color, which is this excessive overwhelm. And one of the things that I love about this diagram, and I use it extensively in consultations, is that it links to what's happening actually in the body. And I've come across this document in learning techniques to actually counsel people who are perhaps reliving trauma in the context of a consultation. And you can see the instructions right down the bottom there is it's a medical emergency and you call them paramedics. And so I have no reservation in saying I've been on every part of that scale. If you go back to the extreme other end of the scale, the parasympathetic one is your classical depression, can't get out of bed, no purpose, no drive, no get-go, want to be in bed and eat ice cream with the doona up under your chin. Obviously, I mean, I could talk for the rest of the webinar on this, so I might just pull back and anyone can ask questions at the end. It's a little bit like the rubber band analogy or the Frank Starling law of the heart. Some amount of stress is useful for functioning in day-to-day life, but when you get triggered into those higher parts of the sympathetic nervous system or the overwhelm of the parasympathetic nervous system, then you are no longer functional. You're no longer able to function, and that is quite scary.
Thanks, Stephanie. And we have a student hub where we have all the resources that will be referred to tonight for the students to go to, and we'll show you how to get there towards the end of the presentation. Now I'd like to turn to, I think, more of a focus on how social discourse and power structures shape and perpetuate workplace cultures which allow sexual harassment to silently take place. So, Louisa, I want to ask you specifically, what are the dynamics playing out in the workplace that would make Sarah vulnerable?
I wanted to go back a step because, you know, I'm a doctor. I trained in an environment that was very hierarchical. I trained in one of the big St. Elsewheres where, you know, the length of your white coat mattered. So that was a long time ago. But I think it's the thing that is really important to say is there's all sorts of hierarchies that intersect. There's the fact that, you know, in certain places, doctors will be perceived further up the food chain than other professions. There's environments where nurses will be perceived as further up the tree, or midwives will be perceived. It intersects. And then you come in, you don't come into medicine completely pristine. You come in with a lifetime's worth of experience of the way that different people behave, and you bring that with you, different traumas, all sorts of things. So there are external things and there are internal things. And I think what Stephanie said is really important, that fight, flight or freeze response. It's not your fault. And the one thing that I really want to say is that it's a reflex. Even with people with PTSD that we have worked on with for years and years and years, recovery looks like they can manage the triggering. It doesn't mean the triggering goes away. So that response is so quick and so automatic. Getting in ahead of it is often very difficult. And if I can just indulge you with a story of mine that I think I told you guys earlier, you know, when I was in my 20s, I had to run a session for the College of Obstetrics, and I was extremely pregnant at the time, and I was chairing a session. And this guy who was probably at my level got up and put up a very inappropriate picture of an overweight woman and said, oh, this is what I have to face every Monday morning. And I will never forget the shame I felt afterwards of why didn't I say anything? Now I would say I wasn't senior enough. I wasn't far up enough. I didn't have the words. I didn't have the status. I wouldn't have been successful. So the one thing that I would say is there are intersecting hierarchies. They come in from all sorts of equations, all sorts of positions. You may be surprised at yourself for freezing. But when you make a decision of what you want to do, you don't just make a decision about what, you make a decision about who, you make a decision about when, and you make a decision about how. And it doesn't matter if you decide the patient is the most important. And I saw this in my studies where, you know, people would be operating and someone would be feeling their bottom and they would say, well, the patient is the one that matters. Yes, they do in that moment. We understand that. That doesn't mean that you've lost all your opportunities if you decide to just push through. You can go away, you can think about it, you can gather your resources, you can talk amongst your crew, you can decide what to do, and you can do it in a measured way, or you can hand it over in some way to somebody who does have the status and does have the power and does have the agency. So I think it's important to think it's not just about policies and it's not just about, you know, this is right and this is wrong. We are human and we do have emotional responses, and there's no shame admitting it because it's a reflex. It's a protective reflex that is part of every mammal, every meerkat, every deer that gets terrified of everything. That's what they do. It's trying to protect you. And so, you know, if you do find yourself in that position, don't feel silly or stupid. Talk about it afterwards when you've got your brain back, literally got your brain back, when you're not being hijacked by all your emotional feelings. And then you can decide how strategically you're going to tackle this, because you can, but it's not always in the moment.
And I think there's some similarities between the hierarchical organisation of the health sector and military hierarchies, which is probably, I think it would be interesting to talk about tonight.
Well, it's different. See, the military, the interesting thing about the military is always hierarchical. The thing that is crazy making about healthcare is we're all nice and even and all got our own opinions and we're all nice and horizontal team-ish until there's a disaster, and then the senior surgeon will take over and everyone will fall in behind. And so the hierarchy is often hidden. You don't think it's necessarily there, and sometimes it is and sometimes it isn't, and you change teams all the time. And the sort of behaviour that you do in paediatrics is not what you do in remote communities, is not what you do in an operating theatre, is not, you know, it's changing all the time. And you guys, when you're starting out, that's really confusing because the social worlds you work in change all the time and you're trying to work out what's what all the time. And that makes you very unsteady in trying to work out what's going on. Whereas at least in the military, you know immediately who's who. The general never stops being a general. But in healthcare, it's not like that. And the other thing is we get to know our patients really well. And when the abuse comes from the patients, it's very confusing because you often think perhaps they're sick, perhaps they're confused, perhaps they've got dementia, perhaps it was that drug I gave them and they're not behaving appropriately. So it's tricky. And that's why I say, you know, I often see this stuff presented as straightforward. We will have zero tolerance, you know. That's not helpful because it is confusing. And you need to sit down and go, what just happened? Like, how did that happen? And what happened to me? And was I misunderstanding something? Or was that a little bit crazy? And it's also okay. People have the right to not report. It is not your responsibility to fix the horrible senior surgeon. Not your responsibility. Now, we can talk professionalism all day, but that doesn't mean you have to be the sacrificial lamb who's the person who gets slammed in a hospital. You can hand it to someone who's a colleague. You can hand it to someone like us. You can hand it anywhere you like. You are not responsible for single-handedly fixing it from the bottom of the tree as a student. It's just not fair to expect it. And there's a great book out there that's about this, and it's about rape culture. And it says, can we please stop fixing the women? In other words, can we please stop telling the women they have to be more resilient, they have to cope better, they have to dress differently, they have to have the keys in the hand? Could we stop making the women responsible? It is not their responsibility.
I'm going to jump in there because I actually think that responsibility has a huge role to play, and this may be controversial.
Yes.
But the circumstances that involved my sexual assault were that I was actually terrified of the awesome responsibility that was facing me beyond graduation. And so we had the question asked before from Meredith about what the vulnerabilities were. The vulnerability was that I was looking for someone of a mentor, someone who took interest in me, someone who was prepared to take me under his wing, And it's interesting, I was reading the article, which I think also should be provided to students, that Louise co-authored, that can retrospectively be seen as grooming behaviour.
Yes.
I mentioned before the duality of men and women, and of course, any other minority group is going to be a target purely from the fact of being identified with being in that group. So whether that's LGBTQI, whether that is Indigenous, whether it's female, whether it's international students, there are a whole range of what we could say inherent vulnerabilities. But I feel very strongly that when we focus on those vulnerabilities, it goes hand in hand with the victim mentality. And one of the things that I abhor about the academic discussions in this space is the victim survivor title, because you're not a victim. You're actually not a victim. The circumstances of any kind of scenario will have a tail, and I do this in my counselling sessions with people, that you can trace. You can always see where the interaction began. So my vulnerability with what, yes, we can say was someone who almost certainly had done this behaviour before and almost certainly was going to go on to do it again. I didn't have the power to stop that. And it wasn't, as you were saying, Louise, on me to either change him or change the circumstances in which it happened. But any event that happens in a person's life can either be the making of them, as it has been for me, or it can be the breaking of them. And it's that breaking scenario that gives voice, pardon the pun there, Victoria, to the victim discourse. And I actually don't see that as a healthy discourse at all, because it perpetuates the powerlessness that suggests that you don't have the inherent ability to harness something inside of you to overcome the situation. And I'm not talking about resilience, because I also abhor that as a statement. This is not about being more resilient of abuse. There should be no abuse, and none of us should tolerate it. But I'm actually going to draw everyone's attention to something that I put in the chat box earlier, and perhaps, I mean, we could go down any avenue for discussion tonight. But I've got a young male patient that comes in. He comes to see me for counselling, and his stepmother is quite an interesting person. I've met her as well, and she's quite controlling. And he has thoughts of throwing himself off the balcony into the gas bottles with a lighter. That's what his suicidal ideation is. And when he walks out, he's a beautiful tall guy. And my receptionists fawn all over him, and it's disgusting, but I have never pulled them up for it. So we also need to talk in this discussion about the role of witnessing this, because it is not a possibility that you will see abuse, harassment, misconduct, lack of professionalism, etc. in your careers. If you haven't already seen it, you will be seeing it. If you're not experiencing it, you will be seeing someone experiencing it. So I'm not coming to you with any tickets of perfection, because here I've got an example where I'm an enabler because I'm not saying anything about it.
Can I just throw in a comment there? And I absolutely agree with you on the silencing. I think it's for me, it's a little bit about picking times that you control the narrative, rather than feeling like you should respond immediately. And I just wanted to give an example. When we ran a summit on this, and we realized that there were 3 reasons why people spoke up. The first was because they needed healing. And it may be that they needed to learn to speak with a therapist before they were able to speak in the workplace. And that's completely understandable. The second was justice. People who felt that the workplace needed to be different, and they wanted to make it different. And the third was safety for others. And one of the successful strategies that I've seen was in an operating theatre with a notorious surgeon. And the person who eventually pulled him up was the anaesthetist. So he was on a horizontal level in that he was a consultant, the surgeon was a consultant, the anaesthetist was a consultant. The person who was touched inappropriately was pulled aside by the anaesthetist. Perfect upstanding behaviour, going, are you okay? Did I see what I thought I saw? Are you all right? And she then explained what had happened, and it was the anaesthetist who stood up to the surgeon. So I think one of the things is sometimes you need to stand back and think and do what you think is right when you want to do it, how you want to do it, with the support around you. You should never feel that you're so alone. There'll always be someone, even if it's someone distant. And if you need to practice talking about this stuff, there's a million, you know, online doctor and student and nurse and health professional support group people that you can call yourself Jane Smith and just have a go at doing it anonymously for the first time to sort of break the ice a bit. And then that might then give you the courage to talk to somebody else. And that's okay. Or even writing it down and never sending it. Those sorts of things might be an intermediate step before you take hold of your own control and agency. But I think, Victoria, that's more your field. I mean, that's for my therapeutic space, a bit like Stephanie, because I do a lot of mental health work too. But I'd be interested from you, Victoria, about your thoughts around that.
Yeah, thanks. I agree with both of your views here, and this is one of the things I've been looking at in my research. How do we move on from silence? And I think the key is developing a sense of agency.
Mm.
So this speaks to what you were referring to, Stephanie, in terms of not accepting that you are necessarily a victim, whether it's silence related to sexual harassment or any other form of silence, and that you can speak up somehow, whether it's indirectly, directly, through collective action, through an anonymous reporting mechanism. It could be face-to-face, it could be via email, however that occurs. But I think you're also right, Louise, in the sense that it may require practice, because I don't think it's something that most of us are particularly good at. You know, we've lived our lives in silence effectively, and often, you know, women in particular around certainly certain issues. So one of the things I'm starting to do is investigate workplace coaching as a mechanism for those kind of conversations where you can have a practice session. And I guess that's a similar role to what you're both doing as GPs, where you have a counselling, a safe environment in which, you know, people can start to express what's going on and how they might begin to deal with those moments where they do feel silenced, or feel for whatever reason that they can't speak up, which is at the end of the day a perception. I mean, it can be a very, very powerful perception, and there can be very, you know, any number of compelling reasons why people, or why one feels one can't speak up. And you know, in the junior doctor scenario, you know, those reasons are, I think, you know, they come thick and fast. There are many reasons, seemingly. But, you know, it's about challenging that notion. Yeah.
It's interesting. We do a training session with our students, and we get an actor in, and we practice with them, and we practice the terms, and then we run a scenario, and they still have trouble speaking up. So it's not unusual to struggle with that, because as a student, hospitals are overwhelming. Like, they're big places, there's life and death decisions, there's a lot of people who are very powerful, and you learn to be silent, you learn to be I hate to say the word obedient, but you are, as a student, like you are a silent person. You're trying to learn. It's quite difficult to get from that point. You know, it takes a lot of learning. So I just wanted to say that, to just say, don't, you know, you can do a lot of secondary damage by being ashamed of being unable to do this. You know, it's just something you haven't learned yet, like doing your taxes or suturing a wound. Like, it's just something you haven't learned that you need to learn. It's not a character flaw that you have trouble.
Yeah, and the word I use in my research is forces. There are a lot of forces that are directed on us as individuals in these large institutions, and the same thing happens in academia. It's another hierarchical setting, as you would also know, Louise, and you've encountered, Stephanie, and I'm sure all of you as students in the university space. So there are, you know, a lot of unseen pressures on us. And it takes some I guess, a particular sort of development to learn how to counter those forces.
Stephanie, did you want to add something?
I'm champing at the bit.
Yeah, I can see you.
One of the things that I wrote down was around having a narrative and how speaking and actually using your voice can be incredibly powerful, and it is. It's one of the reasons why I'm on this webinar. And likewise, there are, so when I saw the guy that was involved, and I saw how I had made his physical personage this spectre, let's say, that was full of the forces, if I can borrow your terminology there, Victoria. And when I looked at him in the setting that he appeared, he seemed to me to be an incredibly empty vessel. And in that moment, he had no power. And even though my physiological response was right there on that polyvagal sheet, I was ready to leave my body. I could feel it. After that encounter, I said, absolutely not. I am staying here and I'm standing in my own 2 feet. And I had incredible support people around me. It's just the way that the situation, let's say, constellated. But after that moment, I was ready to report it. And so I got home and I wrote a statement for the police. And it was 5 pages long. I can type fast. And that was the healing. That was the bulk of the healing. And whilst I literally have just had a conversation with, staying with a friend of mine who's a psychologist, and even this morning there was more to uncover. There was more layers to uncover. And I'll just change gears slightly, because what I wanted to share was that in my first year of medical school, we came to the end of clinical coaching, and all of you in the health professions would have these kinds of subjects. So it's very transferable. And rather than the teacher or the clinical facilitator, as she was called, marking off on our strengths and weaknesses, we had to nominate those for ourselves. We did it as a group. And it was, for me, quite a shocking experience to hear that not one of them could nominate a strength, not one. And it was obvious. I was sat there with someone who was super sharp. She always had the answers. She could always deliver them. And that was, she was like, pow, pow, pow. She always had the recall of the knowledge right there. And there was another guy who had a background as a paramedic in LA, of all places. So he came with this almost fatherly wealth, but was crippled with anxiety when it came to performance in an exam situation. And so everyone was able to write these critical things about themselves, but they couldn't actually see, let alone articulate, what they were actually bringing as a contribution to the field. And that for me has become another reason why I love working with medical students and my colleagues that are similarly junior in their training. I've not been a doctor for particularly long. I'm almost at my 5-year anniversary. But I love to celebrate people's strengths. And I think that's part of a huge paradigm shift in the domination of medicine that is competition-based. Competition-based because you're competing for jobs. Competition-based because, look at me, I'm better than you. Look at my suturing, it's better than yours. And there's many many dimensions and many layers to what I see is possible through Victoria's research, because looking at the effects, if I was to say physiological effects of repressing the voice and of not speaking up, what does that also create in the body? What don't we know about the creation of health conditions, of cardiovascular disease, of obesity? I certainly can say, and unreservedly so, I put on about 30 kilos after the sexual assault because I didn't want anyone to see me. So there's a lot to be said for voice.
Thank you, Stephanie. I'd like at this point to just loop back to the concept of medical professionalism, because I think it's an important concept for us to discuss tonight, because there's idealized notions of medical professionalism and that they can act as obstacles to doctors responding to sexual harassment. So just to start, what do we mean by the term medical professionalism? You're on mute, Louise.
I've been the Associate Director of Professionalism in my university for a while, and it's something I've been tossing around for a while. And what I think is the best definition from my point of view comes from the College of Physicians, who says that professionalism is about increasing trust in the profession. So if you behave in a way that increases trust from your colleagues, from your patients, from your, from their carers, from the community, then to me, that is professional conduct. If you do something that reduces trust, then that makes everything collapse. And that for me is the benchmark. We know that sexual harassment impacts patient care. We know that kind health services improves patient care. If I care for my patient, then it increases trust in the healthcare system. Not just me, all of you, everybody is in the healthcare system. If I treat a patient with disrespect, if I come into the hospital worse for wear because I've been drinking too much, if I'm not aware of my strengths and weaknesses and I do something I'm not trained to do, or I'm too meek and I don't take charge when I need to take charge, if I treat my colleagues with disrespect, all those things comes down to decreasing trust. And my patients tell me, they come in and they say, I can't go back to hospital, doctor. And I'll say, why? And they will recount something. And the last one that made me feel quite sick was two nursing staff, in this case, but it could have been anybody, high-fiving each other about how fabulous they were resuscitating someone next door to her. And she just found that sickening. And she just said, I don't want to be that person. I don't want to have these people looking after me. But what happens if I collapse in accident and emergency? Well, I have people like that. That is unprofessional because it reduces trust. Fraud, taking bribes, all of it is just going to reduce trust. And that for me is that's the bottom line. Can I just also say a brief word about the boards? Because I think while we're talking professionalism, so just to be transparent, I have sat on a medical board. I don't anymore. But the boards of all stripes, it doesn't matter which profession you're in, they might care, but they are not interested in punishing people for the sake of it. They want to make sure that the patient is safe. And so if you come to me and you're feeling depressed or you're feeling anxious or you've got some other health problem, then providing that the patient is safe, that is not a mandatory report. And I think it's really important that people often avoid seeing GPs in particular because they worry that we're going to report them to the board because they're unwell, especially mentally unwell. This is not true. And you can test your GP out. You can say to them, what's your opinion on mandatory reporting? And if they say, I think everybody should be reported to the board, you say, oh yeah, I was just interested in your opinion. I just came in because I've got a sore throat and leave. I mean, you can do this, you can ask questions, but I only have to report people from a mandatory point of view, as you will when you're qualified, if I think they are at risk to the public, not if they're sick, if they're a risk to the public. So if I had severe depression and I took time off to deal with it, then that's fine. The board doesn't need to know. So
Can I just make a comment on that? Because when I hit the purple zone at the end of that chart, I did go to hospital and I did have an inpatient stay, and there was no formal diagnosis of PTSD, but there were certainly many features of it. And I actually made a voluntary report to APRA, and it was terrifying. I will not lie that was an extremely nerve-wracking experience, because despite the teachings on how the boards work, of course, the worst case scenario for any student or young professional is that they will take away your right to practice. Mm-hmm. And I love what Louise has talked about, and it is very reassuring that you don't have a right to practice if the patient's not safe. And I would uphold that. And if I didn't feel that I was safe, I would never have graduated. I actually would not have graduated. But in reality, they took a part of, I consulted with my medical defense organization, and they wrote a very legalese type of letter saying that I was making a report quote, from an abundance of caution, which I have subsequently used shamelessly because I think it's an excellent phrase. And they replied saying, thank you for making the report with the abundance of caution, no further action. And I think from someone who has then had to have psychological and psychiatric care, you just follow your doctor's instructions. Don't get any wise ideas. Just do what they say. Like I say about medications, they do what they say on the box. So you take them for the appropriate period. They work. And then as you work through the issues that arise from these situations, and listen, it doesn't have to be in the context of what we're talking about. This could be about anything. You know, you could have a death in the family. You could have a beloved pet and demise, and anything. Suicide, anything. So whilst we're using the lens of this workshop to focus on, you know, sexual impropriety in the workplace, these really are transferable principles. And I think being able to not be afraid whilst also not trying to change the system, because the system is broken and it will need to break. And it breaks because of our collective voices coming together and saying, I'm not going to tolerate that. You can't speak to me like that.
Yeah, for sure. Thank you. I just want to turn back to the reasons why people choose not to speak out. So, Victoria, from your point of view, what's the standout reason people choose not to speak out?
There are quite a few reasons. So obviously I'm talking about the healthcare context. Essentially, there's a lot of fear in healthcare, and it may be more prevalent in some of the professions more than others. So as I've mentioned, I'm looking at junior doctors, but I'm aware that not all of you will be junior doctors. But let's say that professions are, as we've already discussed, incredibly hierarchical, and particularly, you know, these elite professions where, as has been mentioned, there's a lot of competition. There's sometimes a scarcity of places, employment, etc. So a lot of people hold back because they fear they won't be able to get on with whatever it is that they're chasing. Be that a new job, a renewed contract, getting through a rotation, getting signed off, getting into a specialization if they are in the medical field. So a lot of healthcare employees find that they are hamstrung by the constraints of of the hierarchies in which they work. So that's within their professions. Then there are organizational barriers. So it may be that understanding how to get things done in your hospital or in your environment are incredibly difficult. You don't know where to go. And it's often that these organizations don't make it easy for you to know, and no one particularly tells you how to do these things. So there can be a lot of sort of battling of hard to understand systems. There are obviously individual factors. So people can simply lack the confidence, the know-how, the necessary ingredients of how to speak up, how to express themselves. We all know that public speaking is a big fear that people hold. So it becomes heightened in an environment where you are on professional display and you're starting out. So in many cases, some of my participants spoke about not knowing enough to know when they could speak up about certain issues. So there can be a real uncertainty and self-doubt. And then we talked earlier about the cultural issues. So there can be these climates of silence that form, and people learn by observing what's going on. So as soon as you're a student and you're on a work placement, you're observing how things happen in that workplace. And generally you'll go along with that. So very few people speak up at those junior levels, at the levels that you guys are probably at. And it's usually only in desperation that people seem to speak up. So they're at their wits' end. It's either maybe a patient safety issue that they just cannot hold back on, or something has happened that has made something very, very difficult in their personal lives. They can't get parental leave. They can't get married or whatever it is. So it's those kind of difficult situations that will push people to the edge of being ready to speak up, but maybe they won't be in a good place when they necessarily do that. There's many reasons. I could go on.
Yeah, but I think you covered off on some very important ones, Victoria. Louise, what would you say are the standout reasons why people choose not to speak out?
I think there's internal ones and there's external ones. One of the issues is that the policies are just not transparent at all. And also that the policies often, what's written down is not the way we do things around here. So you're often trying to work out how much trust, and this goes back again, I think often we work in organisations that don't show a lot of professionalism. I have a huge thing about lying, and I think we lie all the time in our organisations. For instance, all you have to do is look at unpaid overtime. You know, there's always a policy that says we won't have unpaid overtime, and yet that's the way we do things around here. So, and one of the trouble with being a junior is you're often changing teams a lot and you haven't worked out the way we do things around here. So you're often unsure whether the policy that's in the book has got anything to do with things. There's also structural complexity. So the first thing to say is that human resources departments are there to protect the reputation of the organisation. And if they have a choice between the senior surgeon and the student, you can see why they're in a really difficult spot. And one of the editors in our book talks about the cup of coffee with Brian. You know, why don't we just go and have a cup of coffee with the perpetrator and we'll just have a bit of a conversation and sort this out. You know, that's a very inappropriate way to, we wouldn't do that with fraud, we wouldn't do it with someone who's stolen money, we wouldn't do it with assault. I don't know why we think we do it there. So often it's difficult. For students, it's often difficult. Do you pick the hospital you're in or do you pick the university? And what happens when those two disagree? Which one do you pick? Are you supposed to go? Which way are you supposed to go? You also have, you have the medical board, you have your medical defence organisations or the equivalent in the other professions. I'm sorry, I'm talking medicine. The book's due in 3 weeks and it's just absolutely stuck in my head, so my apologies. I do think in multidisciplinary terms, except this week. But also, you've also got places like, do you want to go to the Doctor's Health Advisory Service and talk it over there? Do you want to go to the college if you're the College of Nursing, the College of Physiotherapy? There's so many places you can go, and that's why it's often quite confusing. And all those policies often don't intersect. So until that gets straightened out, at our summit, we talked about the fact that you're confronted with a whole lot of doors and you don't really know what's behind them. You know what they say on the front that's nailed to the front, but you don't know what's going to happen when you open that door. Is the perpetrator going to find out? Is it going to cost you? How long is it going to take? So I think it's always wise to have somebody that you can talk to. And I just put up there's always somebody that you look up to that is at a level that's a little bit more senior. And it may not be in this rotation. It may be the person that you saw at Northern Territory when you did that rotation, but they were a registrar and they were really good. Most people will take a call in a conversation, It's okay to look back to somebody else out of the system to just have a off-the-record conversation to get your head straight. That's all right too, because it is a bit confusing. And it is also okay to ask in a nebulous way, to ring up the APRA and say, what would happen if this scenario were true? What would it mean? Where would I go? What would it cost? What would I have to do? Mm-hmm. You're completely entitled to do that. And also, for those of you who have indemnity insurance, which most of you will, that's what you're paying them for. That's their job. Ring them up and ask the question. Because, Stephanie, I've always also been in that spot. When I was a young doctor, I was on opiates for a while for a perfectly legitimate reason. And I remember the board saying in a quite perplexed voice, are they prescribed? And I went, yes. Are you getting them from anywhere else? I went, no. They went, okay, that's all right then, that's fine. But I was worried and I wanted to be trustworthy. It's okay to ring and ask, and you can always say, I've got a friend, it's all right to do that, to find out information if you need to. The internal things, we've all seen this go badly. We've seen women get crucified in the media. We've seen time and time again what happens to them in the courts. We are right to be concerned about what will happen to our reputations. Now, that doesn't mean you shouldn't speak, but there are internal barriers that are hard. And I do think choosing the time and the place and the person is really important. And I actually really like, Stephanie, I recommend that too. The writing down is really important. To get straight in your own head, you don't have to send it anywhere, just to get straight what you need to say, what's important to you. Even the act of writing gets over some of those internal barriers. But I'd be an idiot not to say there aren't hierarchies. And if it was a choice between an intern and a senior surgeon, it's an uphill battle. And that's what makes it so tricky. But often it's the confusion about what we do where, and even the states are different. And I tried to understand law, and it's taken me 10 years of writing this book, and I still don't think I've got it straight. Who do you report to? What happens? It's interesting, isn't it? Because if it was fraud, it's illegal. We would call in the police. I don't think I've ever seen a hospital call in the police with sexual harassment. It's just as illegal. But the behaviour suggests that they don't see it that way or something. I don't know. It's quite odd the way it doesn't get treated like any other crime, because it is a crime.
They call it in for physical
they call it in physical assault. That's right, they do. So it is complicated, but it is absolutely possible.
Thanks, Louise. Stephanie, do you want to add anything, from your point of view as to the reason why people choose not to speak out?
Yeah, I'm going to reference Louise's article here, and that is that the believability of the story, and we alluded to this in the case with Sarah, the ambiguity of whether that was actually an inappropriate discussion that she was listening to, or whether, you know, a quick grab on the tush is like, why would you have a problem with that? I have a friend of mine, this is a true story, who I saw at an event a couple of months ago, and she grabbed me full on the butt, like a full hand grab on the butt. And we both found it hilarious. But that's context. It's always the context. And I think in a workplace scenario, even if there is, I had a policy when I was much, much younger, and that was you don't mix business with pleasure. So one of the things that Louise's article talks about, and particularly in those rural rotations as well, for a lot of the students on the call, is that you can't not mix business and pleasure when you're out remote with a cohort of people, unless you stay in your room and you don't talk to anyone, which I have also done. But the element of causing a fuss, the element of not being believed, that what you experienced wasn't actually all that bad, so you should stop whinging. The element of challenging the status quo, I've got to really enjoy. I actually really relish telling this one. I had a consultant tell me, I was an intern at the time. I won't tell you the specialty. I'll tell you if you ask me privately. And I present like this. I've had a 20-year career in medical transcription typing. So I've been in admin before I decided to put myself through medical school. And I know how to talk to doctors because that's been my job for 20 years. And this, I'm going to call him a character, said to me, you know, you're not allowed to have a personality until you're a consultant, right? And I was placed on a performance management plan. So the way that the system controls people who aren't afraid to use their voice, who aren't afraid to challenge things, is pretty abysmal. And in the end, I resigned from hospital practice because I did meet with lawyers, and I presented a meeting to the head of the then hospital that I was working at, and suggested they had 3 cases to answer for: bullying, harassment, and discrimination. And I suggested that it should stop, and it didn't. So I had that choice there before me, whether I was going to push into a fight, which would have had to be the case, because me just getting on with my business, training as a junior doctor, wasn't cutting the mustard. It was almost like my very presence was irritating to the people who were around me. And for anyone in the healing professions or with a healing bent, you could probably appreciate that is a very distressing feeling if you were going to take it personally. Because by then, when you have the opportunity to sift through and do your healing in whichever way, shape, or form, I'm going to come back to that point in a second, then you don't take things personally anymore. So it was clear to me that there was a nurse unit manager who was insanely jealous. And so when the complaints came about my conduct, about being a bully, it was obviously because she wished that she had the opportunity. You know, I would never have had an opportunity to talk with her about that, but these things became quite clear. So the other thing was that when I presented my statement to the police, my 5-page statement to the police, I had 2 male detectives come out to my house where I lived alone, which was scary enough as it was in the context. And we sat and they told me that the definition of rape was where a woman, this is a quote, a woman gets off a train, a man grabs her and drags her into the bush. That's rape. So they told me very clearly that because I had mentioned disassociation in my statement, and that's coming from a medical perspective, I'm not, you know, gilding the lily or, you know, playing any drama cards or anything like that. They said it would be very hard to get this past a jury. they said I had an opportunity to put it through a civil case. And I can only imagine from the research that Louise has done and the forum and formats that she's been involved in, the impact on the career, the personal impact of going through those kinds of proceedings. And I'm actually not ashamed to say that I didn't have it in me. So, like others in the research that Louise has done, I chose general practice. I chose to train outside of the usual pathway because medical education for me has been a farce. And it's very challenging to continue on in a profession that you may have idealized yourself to be a part of when the very foundation that that profession stands on has been completely shaken, if not proven to be false. Because I'm trying not to swear. The comment that I had is I'm going to swear, any fucker can be a doctor. So that inherent trust that we have in the system, the inherent trust that society has in doctors, the inherent safety that people are supposed to have when they see doctors, that was violated, and irrevocably so. And that goes back to what you were saying before, Louise, about trust. And it goes back to what Victoria was citing as reasons why people don't report. I did report. I reported on my final day of clinical practice. Clinical placement was my last day of uni. That's an entirely different conversation, which again, I'm happy to share, but I don't think there is any right or wrong way to approach this. If you're in the circumstance, there's your way, and whatever healing or learning that you have is for you to unfold. And that brings me back to the point that I parked, and that is my undergrad included creative writing, and I've always loved creative nonfiction writing. So I have done presentations and certainly kept a diary when I was going through my junior years of training at the hospital, post sexual assault, pre bullying, harassment, discrimination, and resigning. And it's very powerful to be able to express to no audience other than you. You don't write for anyone. You just write. You just write, and you get it out of your body. You express it. You say it. And you don't have to say it aloud, because you can say it in the privacy of your pen and paper or your fingers on the keyboard. And so it's very clear to me that my experience will be the subject of a book. It's obvious, because, and really for anyone who has overcome the level of intensity and the consequences of me freaking out about my responsibility where it came to patient care. That was my consequences of freaking out and seeking solace in the arms of, I'm going to swear again, a fuck up. That was my consequence.
Thank you so much for being so open. I think that's incredibly important, Stephanie, and I really appreciate that people like you are able to do that. I just wanted to say, healthcare is a community of humans, and damaged humans, good humans, bad humans, humans who are both good and bad. And that's one of the problems, that often we will want to idolize people. We want to believe that if we got sick, that temple on the hill would have some fancy professor of something who would, wave their fancy doctory wand and make us all better. We want to believe that. And often what's happened to some of the survivors that I've interviewed has been that, it's a bit crazy making, because the famous John Kearsley case, where he was the only criminal case where he pleaded guilty, and he still managed to get 100 testimonials from colleagues saying what a wonderful person he was after he pleaded guilty, because people have a lot of trouble believing that you're both. You've got good parts and bad parts. You're not all evil or all good. And he's obviously good because he's curing cancer, so therefore he can't be evil. You know, it's that. And it's always the, how can this happen in the cold, hard light of day? Because as you say, you know, sexual assault happens in alleys to, you know, lower class girls who wear short skirts, that nonsense that keeps being, you know, circulated. So it is a bit crazy making, but I also think the healing, you know, my work in this space, I always say up front, this has not been my experience. Like many GPs, I came into research because something was wrong. And I looked after an intern who had been sexually assaulted, and he was a doctor, she was a doctor, I was a doctor. And obviously that made the therapeutic relationship complicated, because how can she trust me when I'm in the community that caused her such harm? But it was the relationship with me and people like me that turned her into the amazing clinician that she now is, that I admire to my toes. So I think we are a community. We are, all of us, you know, I've seen awful behaviour from many sources, and, you know, there are narratives that are acceptable and narratives that aren't. So even the senior surgeon on intern sexual harassment is much more acceptable than the senior nurse on doctor. And I think that's why I've seen terrible behaviour from certain departments. I remember being very, I just found it horrendous watching a midwife just grilling this male registrar about, he must be strange to be interested in women. Did he want to hurt women? Is that why he wanted to be an obstetrician? And was he an awful person and he just hated women and he wanted to inflict pain? It was awful. And, you know, again, and that narrative will never be told because it's not the one we accept. So I think hospitals are hard because people just can't believe that this sort of thing can happen, and they certainly can't believe bullying up or harassment up. The standard narrative is the senior on junior. When it goes the other way, it's often even more silenced. So, but there are good people. There are always good people. They're always, you know, medicine is a wonderful profession. I have never regretted for a moment choosing my role. And I've never, you know, I'm 58, I still love my work. I go home every day, and even when I'm at my most cynical, there will be something that I take home that I treasure. I would still be rural given half a chance. I'm not rural simply because my family needed tertiary care. I spent a long time in a rural practice, which is the best experience of my professional career. So I wouldn't want any of the students to walk away from things thinking that this is all terrible and unfixable. It is hard. Yes, there are terrible things that happen. Yes, there are people who are burned out and damaged. There are predators. There are very deliberate people who are bitterly ashamed and are survivors of trauma themselves. There's all sorts of things going on because people are people. But through all that, I love what I do. I admire so many of my profession that are my colleagues and friends. And I still do that. I put this in chat. It's true. You know, I still look at people and think I want to be you when I grow up, and some of them are younger than me. You know, I just think it's a wonderful career, and you can find your way because you will find the good ones. There's always the good ones.
Yeah, I'd like to end on that because I think that that's a really important point about finding the good ones and about aligning yourself, whether you're a student or an early career graduate or a junior doctor, finding those safe people, those people that you could potentially ask to mentor you. You know, I just would be interested, Stephanie, in your thoughts about that.
When I went through medical school, it's always the question, what are you going to specialize in? And although you might consider this a bit of a pithy answer, it's actually the truth. I wanted to specialize in people because I love people. I actually genuinely love people. I love my patients. And I say that unabashedly. I love my patients. There's one family I've seen, every member of the family, the father or the grandfather really recently died with voluntary assisted dying. He was playing it cagey because he didn't want the insurers to not pay out his life insurance. So he hugged me uncharacteristically, and I knew it was the last time I was going to see him. And the joke with his family was, set a place for me for dinner. I would never be able to do that because it would be a gross boundary violation, but I love them. I love the family. I genuinely care for them. And to me, the great, I don't want to say tragedy, but the great poignancy of me sharing this story is that this almost stopped me being a doctor. And I cannot imagine what life would have been like if I was looking at my future, not being able to provide the precise combination of skill, technical ability, intellectual prowess, I'll say it as it is, and that genuine care for people. That would have been a tragedy. It would have been a great loss. And I say that it would have been a great loss for humanity. So I have many mentors, and I'm in touch with many of them, and I'm in touch with many of them frequently. I'm staying in the house of one at the moment. It's fantastic to be able to have people that are allied health and or completely unrelated to the medical fields that can see past the invisible trees that you have to navigate, and you don't realize you have to navigate them until you smack into one. So I would say that with regards to finding mentors, it's, yes, in some ways about trust, but also about resonance. So what that person does, how they speak, how they talk about patients, how they are with patients, what their bedside manner is, if that's consistent when they are not with a patient, is there a switch that they're flicking that changes when they're away from the bedside and they become very cynical or denigrating? Or there are so many people that in your careers you are going to interface with, and it's not just people, it is your colleagues as well. And there are qualities in everyone that I said in the chat before, some of them are not admirable, and there are elements where you can say, you know what, I never would want to do that. I would never want to do that. I never would want to joke about people like that. I would never want to, you know, high five, let's say, to use your example from before, Louise. But equally so, there are the people that are cool, calm, and collected in an emergency, and you want to emulate that. Or they've got such a fatherly wisdom that one of my jokes actually in the consultation room is oftentimes people are telling their story and they're embarrassed or they're judging themselves. And I said, there's only one person, I would usually say, there's only one person in the room judging you. That's not me. That costs extra. So humor is a big part of it as well. And really, there isn't a situation in life that is so drastic that it's worth ending your life for, because this nearly ended mine. And the gravity of that is still sinking in. There's nothing that can't be worked through. There's nothing greater than the power that's inside of you. And if you can find someone who will help to bring that out, then that is everything.
And there's nobody that's worth taking your life for.
Correct.
Yeah. I need to bring our conversation to a close, but I just want to share with the students our Student Hub page. This is a page that we've specially developed. We've got our Health Student page, and we've got all the different activities and programs that we, the Future Workforce team, deliver. But the Student Hub page is there for you as students, and tonight's speakers have contributed to it with the articles that we've referred to, including the door directory, which is the third dot point down that Louise mentioned. It's a fantastic paper concept, and I highly recommend that. As the article that Louise wrote, which is also important for you to read as well. It's not a long article, but it's very well written. And tonight's closing slide also has our speakers' email addresses, should you want to make contact with them offline. Finally, I'd like to say to Louise, Stephanie, and Victoria, your collective voices have dared to disturb the sound of silence. And for that, we thank you. And Stephanie, we thank you particularly for your courage to speak out and to share your story with us. It sheds light on the darkness, but, you know, and it helps us to go forward. Thank you.
Thank you.
We also acknowledge the survivors of sexual harassment and hope that what you heard tonight will support you and your colleagues as you continue your health journey. And a special thank you to Wendy and Evelyn from Health Workforce Queensland, who brought everyone together tonight and made this happen behind the scenes. We'll be back in October to explore a new topic. So until then, thank you and good night.